welcome to the Australian Drug Foundation's Prevention Research Series, helping your patients who are drinking at risky levels. Firstly, I'd like to pay my respects to the traditional owners of the land on which we meet, and also pay my respects to any elders, past or present. We have roughly around 77 people that are online with us sharing today and coming on board with the webinar, so welcome to you, welcome to all of you. This webinar is particularly around answering your questions, so if you've already submitted some of those questions, we will ask those for you, but you can ask them throughout the webinar and we will make sure that they are answered. There will also be a couple of polls along the way that you can answer, and the webinar will go for about an hour. And I've been asked to advise that if you have any technical difficulties, please don't hesitate to enter something in the chat line, and Redback, who is hosting this service, will be in touch with you and help you through it. We will also have a participant survey at the end that we'll ask you to fill in, so please do so, because any feedback we have helps us define future topics. Well, I'm Julie Rae, and I'm the Head of Information and Research for the Australian Drug Foundation. The ADF is not, the ADF is the only national alcohol and other drug organisation that provides information on the harms of AOD and delivers programs with a primary prevention focus. Our article, which featured in the Australian Doctor earlier this month, was written by Dr. Simon Holliday and Dr. Hester Wilson, both GPs, and it's great that Hester is able to be with us today. Along with Hester is Dr. Grinzi, who's, and I welcome both of you to this webinar, and thank you for joining us.
Thank you very much.
Well, the majority of Australians drink alcohol for a variety of reasons. We celebrate with it, we commiserate with it, it relieves our boredom, it keeps me company when I'm lonely. I've worked so hard, I've earned to have a drink, I believe that I've earned it. It's everyday part of our lives. But in the main, the majority of Australians drink at quite, they're stating they're drinking at quite good levels within the Australian guidelines. However, around 20% of those who consume alcohol are doing so at risky levels. Unfortunately, over 5,500 people die each year from alcohol-related illnesses or injuries, and around 160,000 people are hospitalised from alcohol-related events. So it's definitely up there in the world stats in terms of morbidity and those sorts of things. So Paul, tell me, do GPs ask about alcohol?
It's a really interesting question. Thanks for the introduction, by the way. There's over 14,000 GPs in Australia, and it's hard to sort of summarise the response in a simple statement. The answer is it depends. It depends on the situation and the GP and the community. So there's a lot of variables. We do know that overall, alcohol is under-screened across primary care internationally, and Australia is no different in that area. So I suppose we've got some work to do, and I suppose this webinar is part of that education for our GP audience to improve our skills and our knowledge about inquiring about GP and then what to do about the answers when we do inquire. So Hester and I have put together an introduction to the evening which supplements the article that was in the Australian Doctor How to Treat section last week. So if you haven't read that, it's a really great resource that Hester and Dr. Simon Halliday put together, and I'd encourage you to read that if you haven't already done so. We've put together an introduction just to sort of summarise some key points from that article and from the alcohol literature about what GPs can do, and that can be best summarised with sort of 5 A's approach. So Hester and I will go through those over the next few minutes, just summarising those. And there's a lot more detail both in the article, and also I'll be referring to the Australian treatment guidelines, which are downloadable off the National Guideline Repository and also the Australian, I think, alcohol.gov.au website. So there's a great resource there that gives you a lot more detail that we can possibly fit in within the hour. So we're going to spend a lot of time today answering questions after we go through our introduction. So let's start with the first one, and the ask, which is the first of our 5 A's. And really, asking is more about us giving ourselves permission as clinicians to actually ask the question. if you're going to ask one question, the question we'd highly advise is the third question of the audit C, and we'll refer to that a bit later on, which is how many times in the past year have you had 4 or more drinks on one occasion? It's a very sensitive question, and if someone's got a positive answer to that, then it allows you an introduction to ask further questions. But sometimes the hesitations to ask that question, how do you fit that in? And so it's really important to consider this a universal approach. We need to be asking everyone. As the slide says, if we just look at who we're trying to pick and sort of do a targeted screening, we won't identify 70% of patients who drink at risky levels. So we need to have a universal approach so we don't miss those that were otherwise falling under our radar. So the first step really is to ask. Once you've asked at least an opening question, you may want to ask a bit further. And you're really looking to then assess a bit more. So there's a number of ways of assessing. You can use a questionnaire approach, and the Audit C has been promoted by the WHO. So there's 3 questions there, and they are: how often do you have a drink containing alcohol? On a typical day of drinking, how many drinks will you have? And then the question we've just covered, how often do you have 4 or more drinks on one occasion? You can use that. You can also use sort of a history-based thing, which we're more familiar with, and would suggest if you're getting a positive answer to that first question, or if you're getting a patient who's in a higher risk category, and we may cover those a bit later on, then it's certainly important to assess this further. Apart from assessing the type of alcohol, the amounts, their drinking patterns, and a bit of their knowledge about their patterns and maybe their triggers to drink, it's also important to look at the consequences of their alcohol use. They can be both positive consequences, but also importantly from our point of view, the health consequences that may lead to further discussion from there. So there's the first couple of A's, and I'll hand now to Hester to finish off those the remaining 3 of the 5 A's.
Thanks, Hester.
Thanks, Paul. Got to find it. Okay, so as Paul said, 5 A's, very, very simple, and it's stuff that we actually do all the time as GPs. We're asking about people's health, we're making an assessment, and then we're moving on to advise them. And once again, this is very simple and doesn't have to take a great deal of time. The Australian Alcohol Guidelines from the NHMRC are very simple. For all healthy adults, no more than 2 drinks per day. You may recall in the past that there were differences between men and women, but what we're saying now, keep it simple, no more than 2 drinks per day. The other thing is the amount that you have on a single drinking occasion. So what we might refer to as a binge, and in this case, it's no more than 4 drinks a day. There are high-risk groups. There are groups that shouldn't drink at all. And we've got up there children and young people under 18 years of age. Not drinking is the safest option. Now, it is the legal age to begin drinking at 18, but when I'm talking to my children and the young people in my life, I always say to them, hey, you know what? Your brain doesn't fully mature until you're age 25, so really you don't want to be using any psychoactive drugs, including alcohol, until age 25. I have to say that I think my capacity to stop my kids and their friends from drinking over the age of 18 is probably limited, but it does actually start an important conversation for young people because they are at increased risk. In addition, pregnancy. Now, pregnancy, there is no safe drinking level, and more we're finding that the fetal alcohol spectrum disorders, we're finding that even at those lower levels there is a risk. And so we would say no drinking during pregnancy. We know that that still happens. It still happens perhaps with almost 20% of women once they know they're pregnant. But also there's a group of women who, before they realise they're pregnant, are drinking. We would say as much as you can advise all your women of childbearing age about the risk of drinking in pregnancy, and that it's important not to drink even when you're trying to conceive, or possibly you could conceive. I think the other thing that I just wanted to just briefly talk about is when we're talking about 2 drinks a day, what does that actually mean? So I think about it really simply. So it's standard drinks. And there's a complex formula you can use if you're clever with maths, or if you're more like me and like it simple, you can talk about the 3 or 4 basic kinds of drinks that we have. So a glass of wine is 100 mils for a standard drink. A glass of fortified wine is 60 mils, and a nip of spirits is 30 mils. So 30 mils for spirits, 60 mils for fortified wine, 100 for wine, and 375 mils for a standard beer. Now, I know in Victoria, Paul, you've got pots and we've got middies up here, but basically a middy is a standard drink for your mid-strength beer. I don't know what a pot is, but, you know, I might leave that to you. But it's a very simple way, you know, so one kind of standard middy of beer, 100 mils of wine, 60 mils of fortified wine, and 30 mils of spirits. A lot of pre-prepared drinks, anyone that's like a pre-prepared, pre-packaged alcoholic beverage will have its standard drinks on the side. So when we're talking about no more than 2 drinks a day, we're talking 2 standard drinks. No more than 4 drinks a day is no more than 4 standard drinks. I would point out, and I know that Paul has talked about this before with the audit, which is a WHO publication, and it is a very well validated score that picks up people's risk not only of hazardous or risky drinking, but also of dependence. What they talk about on that one is no more than 6 standard drinks a day. So the Australian guidelines are a little tighter than the international guidelines. Generally, I talk to people in my practice and use the Australian guidelines. So moving on to the next one. So after you've advised them about the healthy drinking levels and you've made the assessment, you may find that they're in the low risk drinking category. So they're healthy adults, not falling pregnant, don't have any conditions that would make them have more problems with alcohol, for example, liver issues. And you've advised them that these are the healthy drinking levels. However, and you may find that they're drinking perfectly within that and perfectly happy. Or you may find that they're drinking at risky levels. So it's really important then to have a talk to them about the fact that that is risky, even at those levels that really in our culture would be considered pretty normal. You know, and there's people that drink, it can seem like a pretty kind of average thing to have 4 drinks. The fact is that our bodies really don't cope with it very well. As you drink more and more, of course, your risk increases. Tonight, we're not going to be talking about that small group of people in our community who become alcohol dependent. They are a very important group and they have very high morbidity. Today, we're focusing, though, on the higher prevalence group, that group of people who drink at hazardous or risky levels, or what sometimes is called binge drinking. So how do you respond when you've found out, you've spoken to someone about what the healthy drinking levels are, you've found out from your evaluation that they are drinking at risky levels, what do you do then? What we've got here on our slide is this very simple thing, and it's brief interventions. Now, sometimes when I talk to other GPs, they kind of go, oh, I don't know what a brief intervention is. But in fact, we're doing them all the time. We're talking to people about their adherence to medications. We're talking to them about lifestyle. We're talking to them about good diet, about lowering cholesterol, smoking, obesity, all those things that are bread and butter medicine. And we're doing brief interventions every time we have those conversations. So one of the mnemonics that can be quite useful is the flags, which we've put on the slides here. And it's just a very general way that you can begin to talk to your patients about this. And it is exactly, as I said, what we do in our lives as GPs anyway. So give feedback. Let them know what the healthy drinking levels are. Compare that to what they're doing. Ask them if they want to do it differently. Listening to their responses. It's important to not be judgmental, to support them in what they're saying, but at the same time advise them as to the healthy drinking level. And let them know that you're happy to assist. If they want to change what they're doing, thinking about their goals, really important for you to be asking your patients, okay, so we've had this talk, we know that you're drinking a bit more than we know is healthy for you. And also it may be that you, after discussion with your patients, as Paul said, you've found that there are certain things that are not working for them. You know, in terms of the drinking, they're having more arguments, they've been assaulted, they wake up the next morning feeling dreadful, those kinds of things that are happening. And so that you can say to your patient then, you know, do you want to change this? This is a risk, you're having these consequences as a result of your drinking, do you want to change this? It may be that your patient says, no, perfectly happy, don't want to do anything about it. At which point you go, okay, it's up to you. However, I'm here if you want to come back and talk about this in the future. If they do say, look, actually, I would like to change it, then it's supporting them to make the goals that work for them. So really making it a very patient-centered conversation. But make it specific, make it achievable, make it time-based. I guess in terms of strategies, there's a few that we've put down here. One of the things that can be tricky for us, and tricky for anybody that's kind of looking at what somebody else is doing and is trying to support them to do something different, is it's very easy to jump in with the things that work for you. I would say generally that it's good not to do that, to sit back and give the person some space to actually come up with some suggestions of their own. If you are going to offer some, then offer them as curious ideas that they might like to try, that might work for them, have worked for other people, and they might like to give a go. So as we've put here, have a few in your back pocket so you can just say to them, well, for example, I found with some of my patients, if they're trying to cut down on their drinking, that moving to a lower strength beer can help. Or in between each beer, having a glass of water. Or when you drink, drinking with food. Or actually choosing to do different activities that are not based around alcohol. Would be just a few examples. So the next thing is to arrange. This is the fifth of our A's. And I guess for me it's around supporting that person if they want to make some changes. You've made your goals with them that they have sorted out, and you say, well, look, why don't you give it a go and come back and see me? So arrange for some follow-up to have another chat with them to check that it's working. There are a group of people, and it may become clear that this is a tricky issue for this person, and they may not be able to manage it on their own. So it may be that you as an individual feel that you're going to do some more in-depth counselling with them, or you may like to refer them for counselling or refer them to specialist drug and alcohol services. So I'm going to finish there. Paul, was there anything I missed, anything you'd like to add?
No, I think it's a Q&A webinar, so there's going to be a few questions, and there's always a question from Trudy there, and we've got a few that are all posted online in the registration process, and I think we'll cover a lot of the things, and we'll certainly wrap it up at then. But I certainly want to reinforce that although it feels like you're taking more time with patients, waiting for them to come up with goals, it's actually more time efficient if they come up with goals, especially with secondary consultations, because they're actually owning the problem rather than being told what to do by us. We end up with a lot of barriers and a much more difficult discussion. So I'd certainly encourage GPs in the initial phases, while there may be some resistance, just to roll with that and allow the space, as Hester said, because it certainly reaps rewards for those secondary and tertiary consults that we as GPs know as our bread and butter.
Thank you. We'll put our first poll up there to, now for you to actually respond to. Do you think GPs should ask patients about alcohol consumption? But while everyone's jumping onto that, we will. I think it's interesting for us to talk about some of the areas. One of the questions that Trudy has put online is, how do you approach the young person who thinks drinking at high levels just on weekends, as lots of other young people are doing it? So, Paul, I just wondered if you were interested in sort of responding to that.
It's a common scenario that I certainly come across in my everyday practice, where we have often adolescents or even other young adults coming in. I do an assessment, and in that sort of advise role about where I think they should be drinking, this is a common throwback to me saying, well, look, everyone else is doing it, what's the problem with that? And to some extent, again, you can talk generally saying, we know the stats say this and that, but they're not going to really hit the mark with an individual. A lot of us can find reasons to get around why we're different from the general population. So to some extent, it comes down to looking at that individual and how their drinking is, what they're getting out of the drinking, but also how it's affecting them. There was actually, just on that topic, there's a recent study that's looked at whether preloading, so drinking before you go out, saved you money and saved you, problems. So you can buy cheap drinks, drink them at home, and then go out and save money going out. And the study actually showed that adolescents spend more money because they're drunk, and therefore don't have as much thought process, I suppose, once they're out, and therefore drink more. So you can talk about financial harms in terms of actually their drinking is costing them a lot of money. You can talk about injuries, even a sprained ankle coming out of a nightclub because they tripped over and a bit uncoordinated. That's still a harm of alcohol. It's not obvious to the person. So it's making those quick, simple links where things are going. And sometimes the patient will say, look, I've never had a problem at all. And then we talk more broadly about patients we may know or about the broader population. But often there is a clue within the patient's history to bring it back to them. And then that opens a discussion about where they want to go with this and you know, looking at the pros versus the harms. You know, alcohol is not completely harmful, otherwise it would have been banned and no one would be drinking it because it's completely harmful. There are benefits to individuals, but as we alluded to at the start, it's a cultural thing in Australia, and there's certainly a lot more harm from binge drinking as well as regular high-risk drinking than a lot of our population are aware of. So part of our role is making people aware of that.
So what I'm finding interesting, sorry,
can I just make a comment about young people and alcohol? I do a lot of work with young people, and one of the things that I find is really useful is to actually tell them that actually the majority of young people do drink within healthy range. It's, you know, there's this idea out that all young people are binge drinking, but in fact the majority don't. The other thing, there's some recent research looking at working with young people around changing drinking, and the two things that showed a change in behaviour if you've got a young person who's drinking at risky levels was to talk to them about the benefits of not drinking rather than the harms of drinking. The benefits of not drinking seems to have greater agency for young people, and also teaching them alcohol refusal skills.
So what I was going to say was that the majority of young people are not drinking, and we don't say that enough. That all the surveys and all the statistical data are showing that the majority of young people are not drinking. And what's really good since the release of the last household survey on alcohol and other drugs was that the age group of when they're first starting to drink has risen. So that's really encouraging as well. So you mentioned, Paul, about oh yes, thank you, the poll. It's a bit hard to see from over there. Oh, look, I suppose the answer to that poll, you would be quite amazed, would be that the majority of everyone said 100%, said yes. So it's quite surprising. So thanks for that contribution. So Hester, I was going to ask you about the Paul raises around the health benefits that sometimes we see that people say, oh, well, this is good for me. A glass of red wine is really good for me, I can have that. So I just wondered if you wanted to comment around that in light of some of the research that's just come out too as well.
Absolutely. Look, what's clear from the recent research is that the health benefits from drinking at lower levels, for example, the glass of red wine, have been totally overstated. And what has happened with that early research was that it didn't control for selection bias. So in that group of people who are drinking at those lower levels, as compared to the people that are not drinking, this idea that people at lower levels are going to have better health outcomes, it's really biased by the group of people that have been studied looking at who isn't drinking and who is. And there are a group of people who are not drinking and not drinking because of their health, because of their poor health to start with. So, really, I think we've debunked the myth that drinking a couple of glasses of red wine is actually good for your health. Having said that, as Paul says, people do have benefits from drinking. It is something that we enjoy doing and is a social thing. You do need to talk to your patients about that. But it is important to debunk myths.
Okay, well, we have another question here from Jessica, who's a medical student. Could these techniques be used in helping fellow practitioners who have alcohol problems? Was the question.
Wow, what a good question.
So the 5 A's that you've talked about, can you help that with your fellow?
Absolutely. Look, the 5 A's that Hester alluded to is not alcohol specific. It's about behaviour change and facilitating that. So it can apply to a number of other areas. It's not just, not alcohol specific. Weight loss, appointment adherence. If people are running late all the time, you can utilise it for a few different reasons. And so, with a colleague, the question was fellow practitioners with alcohol problems. It depends. There's a number of layers with this. If you find that you've got a colleague or even a friend, someone you know well, you can still apply part of this. There's a couple of other providers with that. One is maintaining appropriate professional boundaries. So unless you are their treating practitioner, you need to refer them to the treating practitioner. But as a medical professional, you should be able to, or even as a medical student, you should have enough knowledge to provide simple, basic advice and see how they respond and whether they acknowledge that there may be some harms from that point of view, and then guide them in the right area. We do have some resources later on about where to go for help with this, and I think on the slide at the moment we've got how to deal with, there's a few good reasons about notifications and things. So there's a couple of layers here. One is about boundaries between you and your colleague, and I'm assuming they're not your patient. The other thing is about mandatory reporting and when do we need to do that. And it's really an extra level of drinking and harm where it's actually affecting and impairing someone's ability to work. And the resources, we haven't, I mean, if we talk about that in depth, we'd be using up our hour plus some in terms of that topic itself. But there's some really good resources that are already up on the slide there for those that really want to go into a bit more detail about that extra sort of level of things. But certainly the 5A's approach, if you want to use that, or the approaches we're talking about tonight, are applicable across the board. It's not a particular demographic specific. They do work well, but you need some bit of practice to get them coming off the tongue quite smoothly without sort of stumbling over your words sometimes, to be honest.
Okay. So Hester, how can other health professionals convince alcohol-addicted people to go see their GP? Now, this is from Mika, who is also a student.
I think that that's in a way, the answer is similar to what Paul has just said. The added complexity to that is that this is someone who is alcohol dependent. And if you're alcohol dependent, the risk that this may actually affect your ability to function and to perform well as a professional is much more likely to be impaired. And we do have a responsibility to, if we're aware that these behaviours are happening that are putting people at risk, to act on that. Ideally, what you want to do is once again, as Paul said, you need to maintain those professional boundaries, but support that person to actually seek appropriate treatment. If that person is unwilling to seek appropriate treatment and you are very concerned that their function as a professional is impaired and may harm people, then you actually have to act and report on their behalf. And perhaps one of the hooks you can use to get someone to go to treatment is to say, look, if you don't do something about this, I'm going to have to report it. The other thing is with the whole process that's set up to support impaired practitioners, that if the practitioner actually reports it themselves, that's seen as being a really positive step to them starting to change their behaviour. So if you're talking to that person, encouraging them to seek help, because the whole process of that, of those support structures, is to assist that person to recover so that they can maintain their professional life.
Yeah, but if I'm a health professional and I'm seeing somebody who is not another health professional, so I'm seeing someone who's for other reasons, and I think they have an issue with drinking, how can I convince them to go to their local GP?
So if you're seeing them for something else other than a GP, so for example, if you're a pharmacist or their dietitian, okay. I think once again you can use the 5A's. That if you once again you've asked that question, you've got that history that there are issues in terms of the amount that they're drinking. You can talk to them about your concerns and encourage them to go and see their doctor. And I think it's important not to underestimate the power that another person's concern, and particularly a professional, can have in actually helping people to see, oh, gee, maybe this is a problem for me, and maybe I do need to go and see someone. If you as another professional are concerned that the person is really at risk, I think that you're not in a position to be ringing up that doctor and saying, I've just seen this person who's your patient, I'm really concerned about them, unless there is a really significant immediate risk. And ideally what you'd be wanting to do is, if it might be helpful, it might be something that would be helpful for them, to actually say, look, can I call your doctor and let them know, so that introduces this tricky subject for you, so that you can actually go, and I'm supporting you to get there.
Well, thank you. That actually is a good segue into our next poll, actually, which is how often do you see patients who are at risk from their alcohol intake? And there's a couple of choices there that you can answer. So while you're doing that, I did want to talk about risky drinkers. And so we know why people drink. We know the harms that alcohol can cause. But we at the Australian Drug Foundation also know that those who have a number of different risk factors have a higher propensity to have to misuse alcohol. and the same would be for other drugs, but we're only talking about alcohol as well. So one of the things is if you can identify some other factors, whether it's isolation, loneliness, boredom, those sorts of things, can that help you as a GP? And I'll get both of you to answer that if that's okay with you. So Paul, can that help you to do the 5 A's, or is it immaterial?
I don't think the 5 A's need to encompass the socio-demographic context necessarily. They apply pretty much. They can apply pretty much across the board. So they're not. You don't have to sort of consider someone whether they're well off or not in terms of assessing and using the 5 A's from that point of view. But the contextual environment someone's coming in is vital. I think as GPs, and this is nothing new. GPs do this all the time, whether we're thinking about it or whether we're just doing it intuitively. We consider someone's background, their language skills, their educational background, their financial background, the suburb or the town they've come from, their childhood bringing up, all the things we've found out over time, little piecemeal bits of history. We put them together and we try and package our consultation within that context. With alcohol, there's both the opportunity to deliver information and receive information within a context that suits your patient, so you know your patient. It's a very patient-centric consultation. But it's also important to consider that these factors, particularly the more negative socio-demographic factors, the determinants of health that lead to poorer health, actually put people at much higher risk of developing alcohol problems and at much higher risk, I suppose, of not being able to deal with them as effectively as someone who's otherwise well supported, got financial backing and a number of other things. So those that are unemployed, homeless, poor, estranged family, other medical comorbidities, really high risk patients are going to fall into the alcohol trap probably more readily, but certainly fall into that and have much more difficulty getting out. So we've actually got to focus on those high risk groups. Alcohol affects all our population. There's not one demographic that's spared, but there are certain populations we have to actually work a lot harder. And that's where we have to use our teams around us. So it's very difficult as an individual GP to take control of all of it. But we can certainly use our community health centres, the allied health people we work with already to try and help with that. And we've got a number of resources as part of this webinar. They can also help if you're not sure where to go from an alcohol-specific resource. There's some great resources out there as well.
So what we've got is around 33% are saying that once or twice a week they're asking their patients, and some all the time. So it's good to display that up on the screen. So Hester, how would you answer the question?
Sorry, from the poll or from
poll.
The one you asked?
So about risky drinkers, identifying people who are at risk over other.
Sure, and I think one of the things that Paul and I would like to really make clear is that we would encourage every GP in the consultations with all their patients to make asking the questions about alcohol use universal, that it's a universal screening. However, there are, as Paul said, a group of people who are more at risk and who can find it more difficult to change their behaviour. And the one group that perhaps didn't come out in Paul's answer was people with significant mental health issues, and the combined issues of the way that alcohol misuse or hazardous use can feed into people's poor mental health and vice versa. I want to say just a quick thing about the poll. How often do you see patients who are at risk from their alcohol intake? I'm looking at the people that have said, all the time, and I'm thinking maybe they actually work in drug and alcohol. But for us in general practice, given that probably 20 to 25% of the community are drinking at risky levels, we're going to be seeing this. We're going to be seeing this more than we think. And that's why I think we need to be asking this as a universal question for everybody over the age of 18.
Yeah, and I think the interesting thing for me also is that there's recently in the British Medical Journal, some information came out about we have to also treat age differently as well.
Oh,
we talked
absolutely.
before about young people, and Hester, you talked about brain development with young people, which is extremely important. But also there is a growing number of our older people who are drinking at risky levels. And what may be 2 standard drinks for me may be not very good for someone who's older.
Absolutely.
So I don't know if you want to comment on that in terms of, therefore, do I, you know, I think with older people, my father's 97, they give him free drinks down at the RSL, but the thing is that we also think, well, they're on their way out. Should we do something about that? So, you know, what do you do with an older person who might be drinking at this level?
They may be on their way out, and as we all are. Going out with a broken hip is probably not the most fun way to go out. So
exactly right.
And you're right, in terms of the effect of a certain amount of alcohol varies across the different demographics, and the elderly often are certainly under-screened by us, myself included. It often just goes under the radar. So it's important for us to keep it on the forefront of our assessment questioning. And once we've asked those sort of questions, then realising that even a small, what seems like a reasonably moderate amount of alcohol for that individual, because of the changes of ageing, can have quite a significant impact both on cognition, which is already possibly impaired through the ageing process, as well as physical coordination. The risk of injury is much higher, and over the lifetime, the comorbid conditions that come along with age are much more likely to be present. So the alcohol has a greater effect, and we've probably got, if we're looking for bang for our buck, that's probably one area that we're under screening, and we can have a significant input on the quality of our elderly life.
Yes, sir.
Look, the only thing I would add to that is, once again, for the elderly, absolutely, we do under-screen. We're a little bit more reluctant to ask about that. We may not think that it's an issue, but what are healthier drinking levels for an Australian adult are not the same for the elderly, that they're much more sensitive to it. And they're a group of people who have quite often multimorbidity, they may be more isolated, mental health issues can become an issue in older age as well. So once again, it comes back to universal screening. We do need to be asking all our patients about their alcohol and their drinking history.
Well, I think that's a really also great segue into our next poll, which is around how confident are you in asking about and assessing your patient's alcohol intake? I think, do we lie as individuals when we're with our GP? Do we actually tell the truth about the fact that, you know, I only drink once a week or something like that?
I think there's two factors that we can make this in our favour in terms of getting a more accurate history. The one factor we've already alluded to is, over time, patients get to know us, we get to know other patients, and sometimes the history is fed to us. And questions at the initial assessment were no. A month or 2 or 5 years later, we found out later that they weren't quite as accurate at the start. So it takes a bit of time to develop that trust. And there's been some good research into stigmatised area, and it's not just this, it's domestic violence, sexual health, drug and alcohol, that if we make sure we've got an environment where there is confidentiality and it's expressed, the patient trusts us, and importantly, they don't perceive a negative consequence by telling us the truth. So if we frame it in terms of health rather than punishment, it's about making your health, making my prescription safer for you, those sort of things, we're more likely to get an accurate history. And the old teaching of, whatever they tell you, just double it because they're going to underestimate.
Exactly.
Old teaching. Our communication skills now are much better, and if we frame it appropriately, we can get a much more accurate picture, provided that perception of negative consequence is reduced as much as possible.
But Hester, it is interesting because there is a bravado-ness around alcohol intake. You know, I've had copious numbers and I'm still standing and those sorts of things. But we do seem to be reticent to admit that we do drink at risky levels to many other people. So your comments around that?
Look, I totally agree with Paul, and what I would say on top of that is, how easy is it to remember exactly what you've drunk and how much you've drunk and what you've drunk in the last month? I think sometimes people actually don't recall. We know that can sometimes be quite tricky for people just to remember, because it's not something they're thinking about. They're not thinking about counting drinks. But I think it's the level of stigma, the sense that you might be judged, you know, and I guess one of the conversations that quite often I'm having with other GPs is, how do I stop my patients from lying? And I would say that that's not a useful way to approach it. That you think about, well, how can I have this conversation in a way that lets my patients know that I'm not going to stigmatise them, I'm not going to judge them, that I care about them and I want them to be well. a very easy thing if you're thinking, I'm not sure if I'm getting a quantity that makes sense, is to overestimate. And, you know, with a group of drinkers that I have who are very heavy drinkers, I might say, so do you have a slab a day? And they'll go, oh, no, Doc, I only have 3/4 of a slab. You know, and so that overestimation can be a way that they can that it feels okay to talk about it. But in a way, it doesn't matter. You know, if there's some underestimation, the important thing is that you're having those conversations and expressing your concern and talking about the risk as a community and the risk for the individual.
Well, just there, I know there's been a couple of comments here, but just before we do that, the results of the poll, it's very interesting in terms of very confidence for people and that they're asking their patients, so it's really good.
So just the 2 poll questions back to back there. Overall, our audience has got fairly high confidence. No one said they weren't confident, although maybe those that didn't actually put that in the poll. It is anonymous, by the way, so feel free to add to the poll. So it seems like our audience has got reasonably high confidence, but in terms of the actual practical application of that, how often they're actually seeing, and therefore would need to ask after that, is much lower. So it's a matter of being aware of this and saying, if I'm confident to ask, then why aren't I asking? It's probably because it's just under that radar. And alcohol is one drug or substance that affects almost every single system of the body. So if you're looking for an opening to ask, look at the patient's history. And there'll be an opening there. Someone comes in with a reflux medication, scripts repeat, you can always inquire about alcohol because it is related to reflux. It may not be related for them, but it allows you an opening to ask. So linking it with a presenting complaint is one way of putting it together so you can open it. It doesn't sound like it's coming out from left field.
Well, thanks, Brad and Meredith, for your comments too. And I think it's interesting there around insurance and not telling the truth around some things, and also sometimes people don't want to tell their doctor because I think they feel that it goes onto their record a lot more permanently than probably telling someone other than a GP about these things. I don't know.
It's certainly part of the stigma of substance use that we would love to just go away and vanish so we can treat it as a health condition that it actually is, but it's certainly a context that it makes it difficult.
Now, at the beginning, I think we talked a little bit about some of the strategies that we can do, and the next poll that's going to come up very shortly is how confident are you in advising patients who are risky drinkers to reduce their risks? And I just think that we could explore that a little bit more. I think will be important, Hester, around what are some of the techniques, because one of the things we say to people is don't get into shouts with other people. You know, don't half fill up your drink when it's halfway full and those sorts of things. So is there anything more that we can do to help people who are at risky drinking levels now?
I think there's some general advice, and we covered some of that before, but I think more than anything else it's to actually personalise it to the individual that you're talking to. Yeah, even with people that have really problematic drinking, the vast majority of people don't want to stop. They don't want to become abstinent. They want to return to healthier drinking levels. And so when I'm working with people, I would be talking to them around, well, what would you like it to look like? What would you like it to be? You know, and is that achievable? So asking the questions around how important is it for you to change this? And if it's not that important for them, you need to do some work with them around getting them to reconsider how important it is. The other thing is, how confident are you that you can change that? And once again, if they're not confident that they can change that, you need to do some more work with them around increasing their level of confidence that they can make that change. And the other thing is that it takes time for people to work through this and get to the point where they're ready to take action to make change. I think that it's can be part of an ongoing conversation, and the really important part of it, one of the things that Paul mentioned, was rolling with resistance. It's a concept that we talk about, where if you're getting the sense that somebody's going, yes, but, or no, I couldn't do that, don't keep pushing with that. You say, look, okay, that's fine. Let's either look at it another way or let's leave it for today, just letting you know that I am concerned and I'm really happy to talk to you about this in the future. When you're talking to people about importance, once again, it is that thing of talking about what are the risks of drinking, what are the benefits of not drinking, how do they see themselves, how do they want their life to be, how important is it to them. And it's not uncommon for people to be coming in because their family has said, you've got to change this. And so it may be that it's from outside that it's being driven, but at the same time, a really important thing is to assist people to see who it is that they want to be in their lives, who it is that, you know, what kind of family member do they want to be, what kind of dad, what kind of mum, what kind of partner, and that can help them to actually feel that this is important for them. And when it's important, it's easy to change. In terms of confidence, some of the stuff that we talked about, not getting into shouts, changing what you drink, you know, going for the beverages that have less alcohol content, eating when you're drinking, going to different environments. You might need to avoid your heavy drinking buddies because it's hard to change that behaviour when you've got those things going on around you. So those are suggestions, but always coming back to the individual around what do you think could work for you? What has worked for you in the past when you've changed your drinking? You know, and those things can actually help to individualise what you're offering for that person. And as we said with the 5 A's, you talk about that, you make achievable specific goals. So it may be that that person's goal is to cut down from 6 beers to 6 schooners, which is like 9 standard drinks, down to 6 standard drinks. And that may not be quite in the healthy drinking levels, but one thing that we do know is any decrease in alcohol intake is a benefit. So it might be that you're working with them around what are their realistic goals.
Can I just give you a little example of that? Even last week I had a patient who was drinking at fairly moderate, well not moderate, fairly high levels, and was starting to make the link of maybe the alcohol could be affecting me. And I opened it up and said, well, you know, we talked about reducing the drinking, and I just said, what's the way that you think you can reduce your drinking? And he said, oh, I put the beer in the boots. And I work rurally, so there was a funny colloquial term, what do you mean by beer in your boots? He said, literally put my beer in the boot. So we broke it down and worked out what it was. And the thing was, he came home from work, and his standard thing was basically go to the fridge, get a beer, crack it open, sit on the couch, and he lost his evening. And he was just basically sort of a sloth for the evening and really felt that it was unproductive, and he wanted to do more with his family and himself, and it was lost time. So that was his motivating factor. And what his decision was rather than put the beer in the fridge and have him there, put it in his boot, so it'd be warm. So he'd come home to a warm beer, not appetising, and then decide if I want a beer, I've got to put it in the fridge and I've got to wait at least an hour or so before it's cold. And by that stage, it's probably got productive. And I've reviewed him this week, and he said, it didn't work every day, but there's a few days I actually got a lot of work done because warm beer, and it was quite warm here, weren't going to go together. And so it was just his idea. I would never have thought of saying, how about you put your beer in your boot? But it was an example of where he came up with the idea, and it worked because he owned the problem and the solution.
It's interesting. One of the things, I don't know if you've heard of Hello Sunday Morning, where people get online and blog about their experiences of being sober. So that's committing to not drinking alcohol for 3 months. So some of those things might be a bit too drastic for some patients. But there are a number of different sites, and Steadfast and October, and these things that we can sort of pledge to remain alcohol-free. But it is hard, I think, for sometimes, especially when you're around other drinkers, to also slow that down. It is, Michael's just sort of said, wow, 101 online. It is great to see so many people online to the webinar. All of this is fantastic, and it's really great that you've been able to work with us on developing this resource. But how does a GP, now my GP sees me for 12 or 15 minutes, how do they fit all this in? How do you get all this fitted into the standard consultation?
It depends on what the patient comes in with. If the easy one is they come in saying, I would like some help with my alcohol. And that happens probably once a year.
Really?
It doesn't come, I mean, probably, I'm making up the numbers there, but it's not a common situation. And it's often, like I mentioned earlier, if you can link it in with what they're presenting complaint, it makes sense to them. It's not like it's a separate topic, it's part of what you're assessing and advising about. Hester mentioned the brief intervention, that flags model, just feedback, giving them some advice, listening to their response, seeing whether they're negatively or positively responding to you, the A's or the advice, setting some goals and the strategies. There's only a few minutes required for one of those to happen. We don't have to be comprehensive every consultation. One goal, one strategy, a review in a week or a fortnight's time will actually achieve a lot more than half an hour diatribe of the whole pros and cons, and it just gets lost. So I think we just have to keep it simple. This is across all behavioural change consultation. Keep it simple, allow patients to own the problem, and with time, that's our value as a GP, we've got time with patients. We can chip away and work on these things. There'll be successes, there'll be losses. We learn from what we consider failures and boost to those successes. And over time, you will see change. You plant the seeds now, they're sown down the track.
And sometimes with those conversations, it may be it's a 1 minute, 2 minute conversation. I've asked you about your drinking history. I've suggested that they're not drinking at healthy levels and you might like to change that. And then you might not see the person again, you know, for another year or whatever. And then in the context of another consultation on another matter, they'll go, oh yeah, by the way, doc, just to let you know, after that 2 minute conversation, I actually changed my drinking. So people do change, and it can be quite an easy process for us, and people do make that change themselves. And even if you've got a lot of stuff, you know, yes, you've only got your 15-minute consultation. One of the things that we do all the time with GPs is we put it in order of importance. You know, so you've come in because you have problems with your blood pressure or whatever. We're going to deal with that. Because I'm concerned, and I ask all my patients about their alcohol use, I've also picked up that this is an issue. I'd like to talk to you about this. We don't have time today. Can we make another appointment?
Look, please don't hesitate to put your questions up online. We've got a few more minutes to actually ask those as Paul and Hester, so please put them up there. Alcohol has been with us for a long time, for centuries. You know, we've consumed it. You know, at one stage we were paid by rum when we first came to Australia in the convict days, and of course it was safer to drink in England than the water was and those sorts of things. But the harms of alcohol are quite severe, and it's growing. The number of diseases and issues are growing much faster. Is alcohol now being talked about a lot more at medical conferences? Is it being seen as a symptom as well as a serious health issue?
Just before I answer that, we haven't got a poll question for this, but in the comments, I would like to take a few comments from those that would like more or less, so we get an idea of where things fit. I personally feel that alcohol as a topic, or drug and alcohol as a broader topic in GP conferences, is becoming a lot more part of the routine agenda. I know at the colleges conference last year, there was a whole day set aside just for alcohol, which hadn't occurred in the past. So it's certainly becoming a bigger issue. What's probably missed a lot on conference agendas is the link in alcohol with almost every other topic. So it has to be an alcohol-specific thing, and when you're talking about diabetes or cardiovascular health or women's health, alcohol isn't often included as part of it. It's very just a one-liner on a PowerPoint. So it's about us as a profession realising that while alcohol can be a single topic, it covers everything. So it gives us opportunity to talk about it many times, but it also needs to be, our awareness is to increase as well.
Sure. Hester.
I agree, absolutely. I don't think I've got anything more to add.
Well, Michael's asking, will alcohol be talked about at the RACGP conference in March?
Yeah, well, actually, thanks, Michael, for that question. I think Michael might be one of the organisers of the International Medicine of Addiction Conference, so thanks, Michael, for that little plug. So the International Medicine and Addiction Conference is being held here where I am, in Melbourne, well, it's actually 4.5 weeks away. So it's I think it's 21st, or that weekend of March. And the college has got a website. Just look up International Medicine and Addiction Conference, and you'll have a look up if you wish to go to one there. Michael's asked another question. Can we have a bit more comprehensive than AusDoc published somewhere else? So the AusDoc article that we referred to is looking at risky drinking. There are previous how to treat articles about alcohol dependence, but I really want to focus on this handbook. Now, I've got a hard copy, and you can only download it these days. They're short of print, but it's the Guidelines for Treatment of Alcohol Problems, produced a few years ago by the NHMRC and a lot of clinicians. It's a very handy handbook. You open up to whatever page you think is appropriate for you. So I'll do a random, and here we go. Providing support to mothers and babies and education to the men in their lives. So it gives you, quite structured on this page, information about how to support families around an alcohol user, in this case paediatric and mothers and things. So very practical guide, and I'd really encourage those of you to get it. You know, if you can get a hard copy, fantastic. Otherwise, at least have it as a shortcut on your internet on the website. And
not to be outdone with sort of promotion here, I would like to also say that the Australian Drug Foundation does have a large number of resources available online, and we also have physical resources that you're most welcome to order and those sorts of things. So the websites are there on the page there in front of you. So there are a huge number of resources that we developed for alcohol and other drug workers, which would be very suitable for you as well.
One of the resources that we can just try and get that slide up, the advisory resources. One of the resources that could be up the slide very shortly, there we are. Each state and territory in Australia have a clinical advisory service. I'm very familiar with my local one, but I'm aware that most of them are very similar. And they're phone services where any GP, most of them are 24 hours a day, not all of them, you can actually phone and speak to a clinician about your patient. So if you're looking for, if you say, I've got no resources around my local area, it's only an arm's length away from that phone. If you can reach a phone, you've got a resource that's actually very valuable. They're not just going to give you generic answers. It's about your patient, your scenario, and some tips and things you can do. So I'd really encourage everyone to at least note what their local clinical advisory service is, because it's a really underutilised service we've got available across the nation.
I just wanted to go back for a minute to the conference that's happening in March, and just to let people know that it's a conference between the College of GPs, the College of Psychiatry and the College of Physicians. So it's a large group of people that are coming together to talk about issues with drug and alcohol. The other thing that's happening, which I'm really excited about, is the use of devices like map of medicine and health pathways that are being developed through Medicare locals. And I've been involved in developing a pathway for alcohol use in my local area with the Medicare local. They're going to be rolled out over the next months and years. And if in your local area you're working with your Medicare local, have a talk to them about what they're doing with their health pathways or their map of medicine, and encourage them to actually focus on alcohol, because the pathway has already been written and you can actually change it to suit your local area. And there's a fantastic way to get that information out there in a way that's really easy for us as GPs to access and to use.
Well, thank you for that. Michael has also mentioned how is the ADF helping the profession to address the issues of incentivising people to drink more. Thank you. We should put you on the payroll, Michael. I think that it's really good for you too in terms of the segues that we're going to. But we're coming to the end of our webinar, and I do need to sort of answer your question, Michael, in this, and that is we have a huge number of resources. One of the things, number of newsletters you might want to subscribe to around Grog Watch, which is where we take the industry to task as many times as possible, who are encouraging young people to drink and also everyone to drink. And we know we do a lot of work around what the evidence is to help people in terms of reducing alcohol consumption, and they're around advertising of alcohol. And we currently have a bit of a sort of what's the word? I can't think off the top of my head, but we're not allowed to advertise alcohol until after 8:30 at night, except during live sport. So young eyeballs can see that then. And the other thing is also about availability and pricing, and they're the two other factors around in terms of alcohol. So we actually do quite a bit around that. So take a look through our websites and you'll actually find a lot of resources. We do, and they're free, we have fact sheets for patients. We have an actual alcohol and other drug online library which has over 1 million resources, and you can join for free online. So they're also available for you. The recording and slides from this webinar will be made available over the next couple of days, and you'll be able to then download it, or you can send it on to a colleague if you like. I would love to, I'd like to thank Hester in Sydney, thank you very much, and Paul here in Melbourne, and all of you for participating, and more importantly, thank you for the Department of Health, Victorian State Government, for their continued support of the Australian Drug Foundation, enabling us to do these sorts of things. So we will be sending a link to all of you to fill in a survey via the announcements box. So please fill that in. Thank you for participating. We hope to see you at other seminars in the future. And thank you to all the people who supported us to make it happen. Thank you, Paul. Thank you, Hester.
Thanks. Good night, everyone.
Bye.